All right. Good morning, everyone. We're going to start in just a few minutes. We have some folks still joining online, folks coming through in the waiting room that are still waiting to join us. So hang on for just a couple of more minutes and we will get started. So again, nice to see you all and be back with you all together. I feel like it's been a while since I've seen some of the names and faces, so it's exciting to kind of be back with you. And again, sort of for what is now part 2 of a 3-part series. So if you are here for understanding implementing selective prevention, you are in the right place. We will, again, sort of in just a few moments, we'll be getting started. I see that there's still some folks waiting to join us online and connecting their audio. So bear with us for another minute. All right. Again, we'll be starting in just a moment. We still do have a few folks in the waiting room that are waiting to connect to audio. So while we're doing that, feel free to say hello in the chat. I see somebody already beginning to do that. Some folks from West Virginia, some folks from New York, Mansfield, yay, Columbus, Ohio. Always exciting to see the sort of the variety of people that are both here in Region 5 with us in the Great Lakes, but also from around the country. It makes for both an exciting and sort of rich opportunity to hear different perspectives when we have folks from east or down south. So no, today promises to be that kind of experience when we have folks from all over the country joining us. Yay, New Jersey, South Florida. Those of you who are again sort of in the southern part of the country, I was just down in Arkansas and got to experience 110 degrees for the first time in my life. So Chicago is not a whole lot better today. I am here in the Midwest in Chicago, and for us today here, it's going to approach 100 degrees. Which is somewhat typical for Chicago, but it's a little uncomfortable. So I'll be indoors today. So again, happy to be with you guys today inside. All right, seeing that most folks have transitioned and connected with audio, let me be the first to welcome you all. And again, continue to type in the chat your name and where you're from. Today's part 2 of the continuum of care or spectrum of prevention and continuum of care, sort of the way that we're talking about this middle part today is more looking specifically a deeper dive into implementing selective prevention strategies. So as we'll get started in a moment, I'll do a little bit of the housekeeping with you all. So next slide. All right. Again, brought to you by SAMHSA, and you're familiar and probably heard at least a dozen times these contract numbers. So acknowledge that this is the Great Lakes PTTC funded by SAMHSA. Want to also, as we get started today, comment about the next slide, talking about sort of our disclaimer. I'm not going to read that to you. So know that, again, I assume you've all seen that disclaimer more than once. You were part of part 1 with us. Again, always a reminder that language matters and that words have power, and that's affirming, and that we use affirming language. We understand people first. So that is part of something we do every single time, which I think is increasingly important. Final couple housekeeping items, technical issues. If you're having some technical problems, you can message Shannon Cassidy directly in the chat, and she will work with you offline through a direct message through the chat. If captions or live transcript would be helpful, you can use your Zoom toolbar at the bottom of your screen to enable that. Select caption, show captions, and you'll be able to follow along more easily if that's something you prefer to do today. So without further ado, I want to turn it over to our sort of series expert who's been with you in part one, and will be with you today and again next week as we finish this series up. Ashley Bodiford has been a director of prevention. She comes to us from South Carolina. In her role there, she's worked as part of an alcohol enforcement team coordinator, done a lot of developed and implemented evidence-based programs in terms of, again, sort of across the continuum, including focused on underage drinking and impaired driving. Worked in the field since 2010 and is skilled in universal, selective, and indicated, which is super relevant to where we're going to go today. So without further ado, turning it over to Ashley Bodiford.
Thanks so much, Chuck. Good morning, everybody, and welcome to our second time together. I really enjoyed being with you all last time for just that nice overview of the updated spectrum of mental, emotional, and behavioral health interventions, as well as being able to kind of really dissect and peel back what universal prevention really looks like, what that means, and how we implement that as prevention professionals, as well as with our partners and other community groups and so forth. So I'm also super excited just to be able to share a little bit about myself with you. Like Chuck mentioned, I've worked in substance use prevention for a nice little 15-ish years, and have had the really awesome opportunity to do several different things, from direct service to training and technical assistance through a regional capacity coaching system, and now working directly as the director of prevention for 2 local communities in South Carolina as part of our 32 network provider system across all 46 counties in the beautiful state of South Carolina. I will echo Chuck. It is hot here. I'm sure my friends in the South are feeling the heat just as much as I am. We are exceeding the 100s and have been for several weeks. So not to rush anything. Time already moves pretty fast, but I don't know that I will be disappointed when we actually hit fall. Although in South Carolina, it's a tease. You think it's fall and then summer comes right back at you. So we've got a few more weeks of this heat, just like most of you all do as well. But again, just want to welcome everybody. Before I forget, it was fun to see, I think Pamela mentioned she is from Rochester, New York. I was born and raised for half of my life in Canandaigua, New York, which I'm sure you are familiar with if you are from Rochester. My accent probably will fool you. I hear that all the time when I tell people that, but I did move to South Carolina in young adolescence. So have been here longer, but it was nice to see a familiar name. So thank you all for sharing where you're from. Also love to see that, just the diversity of who comes to us and who joins, and just knowing that we all bring so many different perspectives and unique opinions and experiences, and it's nice to learn from one another. So I'm looking forward to that today. Just to get us started, it's always helpful to kind of know what we're in for. So I wanted to just share some of our objectives for our next, time together. The first and foremost is obviously the main purpose for us being here is to really talk about what selective prevention is. What does that entail? Like, what does that really mean? We might hear it, we might see it, but let's really kind of peel back those layers and understand, what are we really saying when we are talking about selective prevention strategies, interventions, and what that means. We also are going to spend some time getting comfortable in how we explain selective prevention to the people that we work with. Sometimes that's an easy thing to get away from, is really making sure that we are clearly articulating why we are doing the things that we are doing. And it's easy to kind of just say that this is the best thing, or this is what we know works. But the people that aren't working in our field or in our systems or alongside us often don't really quite understand, right? And so when they don't understand, it's easy to make assumptions and misrepresentations, and creates a little more work for us to have to kind of follow back up and make those connections for people. So really want to make sure that people are feeling comfortable articulating what selective prevention is, who that applies to, and why we have that section on our spectrum. And then also, kind of as we wind it down, I'd like to spend some time making sure that you all understand how to effectively implement selective prevention strategies while maintaining fidelity. So fidelity is kind of one of those like buzzwords, right, in our field. It's important that we, one, understand what fidelity is, but even more so understanding how we maintain it. instead of just saying, yeah, we did what we were supposed to do, but really making sure that we did what we were supposed to do as it was intended with the appropriate group. We monitored things. If we needed to make adaptations, we communicated in the best way. So really getting a nice overarching view of what selective prevention is, what that means, how to communicate the most effectively, and also making sure we walk away by the end of this session. For some of you, it may still be morning. For some of us, it'll just be approaching afternoon. Just making sure we feel the most comfortable with that content. So again, thank you so much for being here and for joining me. I'm super excited to get started. And so let's just go ahead and kick it off. If you were with me last week on our initial webinar, you saw this slide. You will see it again next week if you plan to join us for the third and final series in this webinar. And it's important to just come back to this. We didn't want to just bypass and jump right in to the topic. I just wanted to spend just a few minutes doing a gentle refresher on the updated spectrum of mental, emotional, and behavioral interventions. Shorthand, you know, we love an acronym, is MEB. For those of you that may be thinking that title sounds different than what I'm used to, and if you couldn't join us last week, we talked a lot about that this used to be known as the continuum of care, and now has been updated. And you're going to see just a nice, just a brief overview before we kind of jump in here. I wanted to just point a couple things out to remind you that we do have some shifting in the title, but really what's more important to notice instead of the title change is the sections and the components of this model. And so you see kind of four main pieces: promotion, prevention, treatment, and maintenance. And then within those four overarching pieces, you're seeing, I like to call them chunks, probably would be better to call them like triangles or sections. But I tend to always say that's the universal chunk. So what you're seeing under there are three specific pieces in promotion, which find societal, community, individual, and family. So that's kind of specifically categorizing how we do and how we implement or how we focus populations specific to the work of promotion, which is that kind of general well-being, general overall type indicator. That's a new change. The promotion was divided from one segment into three. It's also really important to note that there are different sizes. And so you'll first see that reflected right there in that promotion category, with community being the largest. Again, we talked about this last time, so just a gentle reminder that that doesn't mean it's the most important chunk. It just tends to mean that is the largest influence, that is the larger group or reach. And it's important that we pay attention to the chunks and the sizes, but all are important and all are very much worth our time and energy. We also just shift and look at prevention. So you'll see right there, three sections. Those three terms should look similar to you: universal, selective, and indicated. We talked a lot last time about the universal chunk. We only just touched on selective and indicated, knowing that we had part 2 and part 3 to come. But again, remembering that prevention is the strategies or interventions, whichever term you kind of like to use, that are really occurring prior to the onset of a disorder, which are intended to prevent that occurrence of the disorder and reducing the risk, right? Also, always prevention is about optimizing to strive for that well-being, that wellness, that's really important. And so what we think about here, when we look at these three sections with universal, remembering that's the opportunity to have interventions that just focus on the general population or a population subgroup. So we talked a lot about that last time. The really big thing to remember with universal prevention interventions is that these are not happening by any type of identifiable risk. So education for physicians maybe, or a skill-based educational curriculum for all middle school students are just some quick examples of universal. So still important to note there. And then you move to selective, which we're really going to dissect today. So just a nice reminder that selective prevention, and again, we're really going to explore this in just a minute. So selective prevention are those strategies that focus on individuals or subgroups of the defined population whose risk of developing behavioral health disorders is higher than average, but not by their own doing. And I'll talk a little bit about what that means in just a second. But a quick example for that might be prevention education or interventions for children who have parents that are incarcerated, for a quick example. And then that last little chunk is indicated. Selective and indicated are pretty similar in size, but just to kind of wind that conversation down, and we'll talk much more about this next week. Prevention interventions under that indicated section are really focused on high-risk individuals who are identified as having minimal but detectable signs or symptoms that may foreshadow a behavioral health disorder, specifically a substance use disorder for many of us working in that field. However, they do not meet a place of being able to be diagnosed. So there's no diagnostics, no diagnosable criteria at that current time. So it could be like an information and referral for young adults who violate maybe a campus alcohol and drug policy or something like that. So maybe they've engaged in some high-risk behavior and they come to us for some services to hopefully kind of alter and shift that behavior, but we're not having any type of diagnosis happen. So just a good reminder there about what those look like and why we section those out that way. And then you look at treatment. And so two things there, and those ones are pretty much the same size. So we don't see a big shift in the sizing of those sections, but we have case identification and then obviously the treatment of the diagnosable disorder. And then we get to maintenance where we have that long-term treatment and then aftercare, kind of like recovery support. You may hear about it known there as well. Something always important to look at is that promotion does have its own little chunk right there when the continuum, or excuse me, the spectrum starts. I told y'all last time it would take me a minute to stop saying continuum, so forgive me. So you have that right there to the initial start of the model, but you also have promotion along the whole bottom, which means promotion is intended to be integrated into all aspects of the spectrum. And so it's always great to remember that and to not box ourselves in and forget about those things. It's also a great reminder to know that there's no place in I did it again. There's no place in the spectrum where prevention should not be, right? We talked about that just a very little bit last week, but certainly services, prevention services stop at the prevention, at that where blue starts and green ends. But in terms of collaboration or support or conversations, there is certainly a place for everyone to kind of collaborate, talk, work together, and identify what's best for communities, for people, and things of that nature. So the importance of being well versed in this full spectrum is very critical and very important, and always something I like to remind individuals about when I train on this topic, because it can be easy for us to see prevention and box into that when we really need to be well versed and understanding of that full spectrum, what each piece means, why it's set up this way, and why we do specific things. So just a great reminder, if you're not familiar with the spectrum, there is lots more information beyond just this webinar that you could certainly look into and read a little bit more about. PTTC has great resources, so I would encourage you to spend some time looking at that type of stuff if you're not well versed, or if this is the first time you're kind of hearing about that. Like we mentioned, also, please feel free to insert questions, comments, feedback through the chat. We are monitoring that to the best of our ability, so we will do our very best to catch those things as we can. And then we have worked in time for a nice chunk of question and answer at the end. So I look forward to reading your thoughts and your questions throughout. All right, so we've done a nice overview, brought everybody back up to speed on the spectrum, whether you were with us last time or not. Hopefully you're feeling comfortable with this content before we jump in to looking at selective prevention. And so for some people, this may be really that first time we're really looking at and hearing about that. And so this is just pulling that out of that prevention continuum spectrum that we just looked at. So really focusing in now on selective prevention and what that really is going to look like, what that really means, and why it's important to understand all. It's very common for us to be comfortable with universal prevention strategies. Many of us probably can talk at length about all the things we do, have done, have seen, know about, heard about that are within the scope of universal prevention, but certainly should be making sure that we are looking and understanding at selective prevention and also indicated prevention, which we'll talk more about next week. So let's go ahead and dissect that just a little bit. It's important to note that with this, we want to make sure that you all are feeling comfortable understanding what selective prevention means. So we're going to first just take a little bit of time and talk about selective prevention and allow you all to expand upon some thoughts as well. So we will look at that kind of throughout, truly. All right. Here we are. So when we define selective prevention, we are really talking about selective prevention strategies that are targeting specific subsets of a total population. So this is a great reminder that we are not focusing on an entire population, right? Like we do in universal. We've kind of shifted and we've kind of drilled down. So that's reminding us why that chunk is smaller, because it's a subset or a subgroup of the total population. This subgroup is a group that has been deemed to be at risk for substance misuse, specifically by virtue of their membership in this particular population. So it's a great reminder here to note that individuals within these populations are identified as being at risk, but not by their own doing or their own choice. And we'll break that down, but it's good to start remembering that kind of now as we're opening up this. And so when we think about, like, what is she talking about? What would place an individual at more risk if they didn't engage in the risk? Because we're used to kind of thinking about it in that way as well. You know, they're here for services because they engage in underage drinking, or they used substances at a high school football game, or brought paraphernalia to a school, right? Like we're used to those types of things and kind of connecting people, and that's indicated prevention, right? So selective sometimes can get a little tricky. And so reminding us that there are prevention strategies for specific populations who are at risk for substance misuse or substance use disorder, specifically because of being a part of a specific population. And so what's really important here is to check our own assumptions. We don't make thoughts, or we're not supposed to make assumptions based on just our own thoughts about what places individuals at risk. We have research and science that tells us what puts people at risk, and it's our job to identify those factors, as well as the protective ones, which we'll talk about in just a second. But what we first want to think about here and kind of emphasize when I talk about that checking assumption and not just making a thought about someone, one of the most common indicators that I hear when I facilitate trainings like this, and I'll ask my group, you know, tell me an example of a subgroup that would be at risk, not by their own choice. Without fail, and you all may already know what I'm going to say, without fail, the first group that people will shout out is children who live in single parent homes. Sure, again, if I could see you all, maybe you'd be nodding your heads. But that's a very common assumption. And I want to make sure we all hear that, because there is no evidence that shows that children of single parent homes are at a higher risk than children of a two-parent household or a non-traditional parent household or anything like that. And so that's an example of what I mean about checking assumptions, because it's easy to say whatever we want to say. And we have to be very cognizant and careful of our words and the statements that we make, especially as being subject matter experts or leaders in a field. And so if someone is leaning and looking to us to provide information and we just make an assumption like that and present that, you know, people take that and take our words for value and believe what we say. And then we have to do some repair work, which can take a really long time and have to spend some time with trust rebuilding, which is not fun. So it's important to be mindful about that we don't just make an assumption and just think like, well, that's got to be one, right? We know what puts people at risk, and we have to make sure we spend time understanding and learning about that. So when we think about memberships in a particular population that might put people at risk, just out of curiosity, just to start to kind of engage you guys in some discussion, if you have some thoughts about examples of at-risk populations, you can enter those into the chat, and let's maybe just kind of peek and see. Nothing formal. This isn't a poll or anything like that, just to try to make some time for conversation and get some input from you all. Anything that's common. Okay, yes, Nicole says veterans at higher risk of suicide based on research that shows, oh, here they all come too fast, that shows they have a higher prevalence than non-veteran populations. So great, right? So our veteran populations tend to be at higher risk. It's not, based on some things that they've experienced, or maybe not having access to appropriate aftercare when they maybe remove themselves from the service or are still in but experiencing things? Absolutely. I see lots about military connected. According to state data, yes, children of parents with substance use disorders is a great one. Great, Carrie. The impoverished, Carla, is wonderful. Family history of substance use, Miriam. Children coming from individuals with substance use, absolutely, Rhonda. Rebecca, people experiencing transitions in life is a great one. Great reminder. Seeing lots of different things. Individuals with family history of SUD, yes. Children with easier access, certainly, right? Individuals with disabilities, great. I'm sure I'm missing some. Survivors of domestic violence, absolutely great. Individuals under the poverty line, great, Deshauna. So absolutely, what you all are listing is great. And again, I zoomed quickly, so if I overlooked anybody's, I apologize. But you all have some really great examples of what it means to be a group that is at risk, but not by their own choice or their own doing, or because they engage in risky behavior. It's just because they're a part of that population, right? And so it's important to remember that. And so when we think about this, we have to think like we treat this group differently than we would a universal prevention group, because they're at that different target. They're at that different level of risk. And so we have to adapt and accommodate to them, to this specific population and subgroup, to make sure that we are being the most meaningful with our time to give them what they need and really desire and crave and deserve, but also to ensure that, always goes back to a funder, right? To also ensure that we are increasing our likelihood for sustainable and successful outcomes. And so if we just take the easy way out and say, we've got a group of kids whose parents are incarcerated, we've gotten a request from the school to, help and focus in on this group a little bit. And we're just going to come in and do, life skills with all of them. Not saying that they may not benefit from the life skills, but we want to make sure that that's the best fit for that group. Could it be? Perhaps each group is going to be a little bit different, right? And so as a prevention professional providing that service, it's really our key responsibility to conduct that assessment and understand, who's at the table, why, what resources do they have? What resources are they limited by? Things like that. And how do we make adaptations and accommodations, and how do we identify appropriate interventions for individuals who are deemed at risk, not by their own choosing, really focusing in on how do we implement selective prevention strategies. And so what's really important is to know is there are right, just like there are for universal prevention, we have effective strategies for selective prevention. And so we're going to take a look at kind of what that means as we work throughout. So when we think about this, we're going to just kind of expand just a teeny bit more on this definition of prevention and understanding what we are really talking about. So when you think about selective prevention, it's also kind of taking that step back and identifying that this is focusing strategy implementation on an entire subgroup, and regardless of the degree of risk of any individual within the group, because they have all been identified at risk, right? Now, some may have a couple risk factors, if we tally marked, perhaps there may be, student A has 2 and student B has 3 and student C has 7, perhaps. Regardless, these individuals are all at risk, right? So it's going to focus on that entire subgroup, regardless of that degree. It also is intended to make sure that this selective prevention program is presented to the entire subgroup because they are at higher risk than the general population. So we're going to do different strategies and interventions with this group because we already know that. So really, they already need a little bit more or something a little bit different than what we would do at the basic, universal prevention level. Again, don't misunderstand and think that I'm saying universal is like the easy way out or that type of thing. It's not. Universal prevention is hard work, and it takes the same level of assessment and understanding and identification of strategy and fidelity with implementation and adaptation and reporting. It's all the same. It's just the strategies are going to look different, and we need to make sure we understand what those differences are and be able to accommodate when selective prevention services are requested of us. Another thing to look at is an individual's personal risk is not going to be specifically assessed or identified because we have that basis solely on we know they're at risk because of the membership of the subgroup. So this is not necessarily a place where you might do like screening or referring with all of the group. Now, again, just as with universal, you may identify that there are people in that population or in that group just by nature. So you could have a universal group where you're doing strategy implementation of life skills to the whole 7th grade. And some of those 7th graders are also going to be in the selective population because they have parents who are incarcerated, for example, or parents who are diagnosed with a substance use disorder. So sometimes there's going to be some crossover. It doesn't mean that that individual shouldn't still take part of the life skills program. It does, however, mean that they're going to need some additional type of service and resource because of their level of risk. So just being mindful about that. Same is going to be true with the selective population, as you may have 1 or 2 in there that start to self-identify that maybe there is some indicated need here. And that would be a specific conversation. And I promise, we'll talk lots more about that next week. So this is just a nice overview. Again, just a little bit more information about understanding really what selective prevention looks like and understanding what makes up the subgroup, what types of things place people at a higher risk and not by their own choosing. For some of us, that's the first time we've ever heard of that. So it's good to just dissect it just a little bit. So thank y'all for your feedback and your chat inputs. So let's break this down, right? Now that we understand a bit more about what that means, let's talk a little bit more about these populations that we've kind of shared. So what we know here is with selective populations, we know that there are risk groups that are already identified by a variety of risk factors known to be associated with substance misuse. And so if you have been around, you have probably heard these things quite a bit. And so we're going to break this down just a little bit, because when we think about groups, we break them down into 3 kind of contexts, I would say, or categories, maybe this is an ideal term. And the first is biological, second being psychological, and third being social. And so when we think about what that means, we are really trying to understand what is placing people at risk in which context, in which category. And there can certainly be multiple, right? It doesn't just mean it's only biological, only psychological, only social. There can be lots of crossover. It happens all the time. But what we first want to understand is, what does that even mean, right? People may think like, what do you even mean when you're talking about biological context? So a quick example here might be that genetic predisposition, right, to substance use disorder. Biological, you can't change your biology. It's kind of what it is, right? Brain chemistry, brain development, things like that are what I mean when I'm talking about biological. So things that are just kind of already there. So placing you kind of in that spot. The next one we talk about is psychological. And so this one is more about in like their own psychological. So what may surface for individuals in the psychological context when we think about risk factors could be things such as, negative thoughts of self, of others, just kind of that chronic negative thinking. Could be something like low self-efficacy. Could be something like individuals that really lack empathy for others or for situations. Could be another example could be like poor impulse control, right? Those are some common risk factors that you're going to hear and associate with when you're looking at that psychological context. So really understanding what that means is really important. And how they differ, right? And then the third one is social. And so this one is really looking at like the surrounding, like where that individual is and what's impacting them from that social context. Sometimes social can change, just like your environment can change, and sometimes it can't, just depending on certain things. So when we think about risk factors at the social level, you can think of things such as living in poverty or under the poverty line, things like social isolation, right? So not having that connection to others, and you're just kind of in that isolated bubble and not really having the ability to connect or converse or communicate or engage with people like you, not like you, doesn't just, it depends, right? But it's important. Connection is important for our people. And so limited connection or increased social isolation is certainly a risk factor that can create some long-term problems. And then another one to think about here in social might be limited access to community resources. So we say all the time, and I say I'm not pointing at y'all, I'm pointing at myself too. We're famous for saying things like, we have so many resources, and I can't understand how people still don't know about us, but they don't, because they can't get to us. They don't even have a method to maybe learn about us or hear about us or know about us. And so this is just a great reminder too, to think about, are we reaching out to the pockets of our community that, one, probably need us at a higher rate, and two, can't access us. So they have no way to know that we exist, what we offer, how they can access those resources. So it's one thing to have resources, it's another thing to make them attainable and accessible, right? So it's a really good reminder to think about how we do that. It's not enough to just say, we have all these things, I don't know why people aren't accessing them. We have to go out and create that awareness and create that connection to community and connection to resources people know how to access and what to do and what's needed. So just some great reminders there. We also think a lot and talk a lot about risk and protective factors in all of our work in prevention, but specifically for this context, it's important to be just reminded that we understand that those risk factors are those characteristics at those levels, right, that precede and are associated with that higher likelihood. It's also important to not forget about protective factors. And I talked about this last week, and just want to make sure I insert it here as well, because it certainly is true that these protective factors are also characterized with that association of that lower likelihood of negative outcomes that are going to reduce a risk factor's impact. And so we want to make sure we have a nice holistic understanding of both of them. And so just thinking about what that looks like and what that means in the work, it's important to remind ourselves that because people have relationships within their communities and larger society, we know that each person's biological, psychological characteristics are going to exist in multiple contexts, like we just were kind of talking about. And so what we also know and need to be mindful is that a variety of these risk and protective factors really are operating within each context. So it's very uncommon to just have one. It's very common to have several that pop up that we can identify and have that crossover, right? Some may be more impactful or more kind of rising to the top is what I like to say, but certainly we want to make sure we are understanding of all and what that really looks like. And so by knowing that risk and protective factors operate and exist within multiple contexts, we need to make sure we're targeting those multiple contexts with our strategies in selective prevention. Because if we only target one context when we're addressing the risk and protective factors, the reality is it's very unlikely that we will be successful, because people don't exist in isolation, right? They exist in multiple contexts for the most part. And so we need to make sure that we are being mindful about that and understanding how risk and protective factors are influencing one another and influencing the people that we're serving, and identifying how we can implement and identify with that type of work and that type of strategy. So just a great reminder here that, risk groups are going to be associated kind of across three overarching themes of biological, psychological, and social. But even within them, you have family, community, school, individual, there's lots of other pieces. And so I won't get too carried away on risk and protective factors, because I know that that's not specifically what we're here to talk about. However, it's a great reminder that there is still so much correlation, and it isn't enough to just say, oh, we have a group at risk, and we're just going to implement this program because it's what we've done forever and ever in a day. It's great to be comfortable with your programming if it's producing successful outcomes, certainly. However, if sometimes we don't always remember to assess those outcomes and make sure that it is successful and is deemed the most appropriate. So just a great reminder that we want to check back in and make sure that we are doing that assessment to determine that. We also think about a lot of subgroups. So you've heard me reference that a bit, and some people may be asking, like, what is a subgroup? What does that even mean? And so this is just a very, very short list. Truly, we could make a much longer one, and y'all are certainly welcome to add more into the chat about what you could think of as other subgroups might be. Some of you have already started doing that. So if you want to add more, certainly feel free to do that. But what we're kind of thinking about here, just in general, just kind of quick surface, you could identify subgroups through gender, through age, through family history of substance use, family history of mental illness, family history of behavioral health disorders, things like that are what we mean by family history. And the cross of several of them, it may be common that there may be multiple family histories. As well as place of residence, neighborhoods, things like that come up quite a bit when we're talking about specific subgroups and how they're being impacted. I see a question in the chat, so let me peek at this. This is asking, would you classify a mental health disorder as a biological or psychological risk factor? That's a great question. I just broke my kneecap as I lifted my leg to shift. I apologize for that loud noise. So I think this is a great question and one that comes up quite a bit, right? And so again, just a quick double ask, would you classify a mental health disorder as a biological or psychological risk factor? So I think it could be both. And I'm so sorry to be one of those people. I think there are ways to think about this. So if we are identifying an individual who has a predisposition of mental health disorder in their family, right? Then in that situation, in that context, I'm going to place that in biological because that came to me. It's a predisposition. There's nothing I can do about it and I can't change that, right? However, there's lots of conversation around developing mental health disorders regardless of family history. And so in that aspect, in that capacity, there could be some connection to that being more psychological. Maybe it comes from past trauma. Maybe it comes from a situation in which that individual experienced something that related or created, some long-term mental illness there's no connection to predisposition. And so while it could be a biological thing, right, because it's a brain change, and psychological is more about that low efficacy or lack of empathy or poor impulse control, it could be a result of maybe a psychological situation or a past trauma or something that has now created a brain change, which maybe leads more back to the biological standpoint, but just not the predisposition side of things. So I would lean more on biological, but also note that it could be impacted by something that happened psychologically that did not indicate that there was any predisposition to that mental health illness or that mental health disorder. So I'm hopeful that that answers your question. You're certainly welcome to add more into the chat if you would like, but for me, that's how I would quantify and classify that question. That's a great question, by the way. Thank you for asking. All right. And great, Kelsey. And again, certainly feel free to add in questions as you all have them. You certainly do not have to wait until the end. If questions are on your mind right now, pop them into the chat and we will get to them. All right, so with that just gives us a nice overview, again, of really understanding those contexts at the biological, psychological, and social level, and how really all three of them contribute. Just like we talked about early on, one is not greater or more important or more impactful than the others, just like the chunks on the spectrum. All are important and all need to be kind of thought through and considered as we are working through this work and working to identify strategy as we move through selective prevention. So now when we think a little bit more about specific populations, right, we've kind of talked about subgroups and looking at that is helpful, but really dissecting like what is an actual selective population, and y'all listed most of these in the chat. So we're going to talk a little bit about these and then expand on just a little bit here in a little bit more. So moving to those populations, These are just some basic examples of selective populations. So when we're talking about who are we focusing on, who are we working with, who are we trying to reach in terms of the work that we are doing, specifically in selective prevention, obviously, because that's our context here today. So when we've talked a lot about this already. We've mentioned that there are specific subgroups, there are specific populations that are going to be the recipients of this service or of these strategies. And so the first one that's obviously going to come to mind the most at the top of the list for many people, especially working in substance use prevention, is going to be identifying that children of individuals or persons or people with substance use disorders are going to be in this selective population. And it's important to remember here that this goes back to that biological context, meaning that you have a genetic predisposition because you have a parent or a family member who has a substance use disorder. And there's no way in which you can change that. And there's no way in which you chose that. And there's no way in which you really get to remove from that group, right? We certainly know people with substance use disorder can seek treatment and enter into recovery, but that's something that stays, right? It doesn't disappear or go away, that substance use disorder. And so identifying early that children of persons with substance use disorders are deemed at a higher risk than those without is important. What this does not mean is that they are automatically going to also develop a substance use disorder because of that predisposition or because of that involvement or membership, we like to call it, in that subgroup. That's not an automatic indicator, just like it's not an automatic indicator that children of non-substance use disorder parents will never develop a substance use disorder, right? They both can get to the same outcome. They both can get to the place of substance use disorder. It just means that our individuals who have parents with substance use disorder are already a little closer to the target than those without. It doesn't mean more likely, less likely, will happen, will not happen. Just means at a greater risk, right? At a greater risk. So it's important to remember that. It's also important to communicate it like that. Certainly people are still learning and understanding that substance use disorders are a disease, a chronic disease of the brain, and what that means long-term and who that impacts beyond just themselves. And so it's our responsibility to communicate this the most effectively and appropriately, as we always are working and striving to reduce stigma associated with substance use disorders. It's also important, again, to make sure that people understand that there are resources available, right? And so it isn't just about making sure that mom or dad or the family member gets access to treatment services, which is really not our scope to obviously provide treatment, but certainly to help make the connection. It's also about making sure that just as we know substance use disorder impacts the whole family, we can offer services to help as that whole family gets to that place of recovery, that whole place of wellness and wholeness back again, right? And so being able to communicate that effectively is really important so people understand. It's also important that we make sure we've done our due diligence as prevention professionals to seek and attain and acquire the necessary training that comes with these types of services and strategies. And so even though our hearts may be in the very best of places and our intentions are, again, the purest and kindest and the most hopeful and promising, we really want to make sure that we are never doing any harm to any of the people that we're serving, right? And so individuals who are children of persons with substance use disorders are already experiencing certain things probably that we know can certainly happen or that they may be exposed to. And so we want to make sure we're doing our due diligence to provide that service, that strategy that's going to be more of that protector, that help, that resource versus anything that would harm or create any type of judgment or shame or stigma led type of feeling. So just important to remember those things when we're talking about some of these selective populations because of what they're already experiencing, the vulnerability in which they come to us in, and just being mindful about kind of what that looks like. The second example of a selective population can be around children of incarcerated parents. And so again, this is another one that we want to be gentle with and not create assumptions that just because we have an incarcerated parent means XYZ, right? it's not a direct correlation that because one had it, one did it, one experienced it, then everybody else will too. It doesn't mean that. It just creates an opportunity for us to identify that these individuals are at a greater risk because of this situation. And they, it wasn't their choice. They weren't engaging in risky behavior. It's just the population that they find themselves in because of the situation, right? So a great thing here to think about is how do we connect with these people, right? And I'll continue on this list in just a second, but just to kind of break down each thing, that's a lot of the feedback we get is, well, how do I even connect with children of parents who are incarcerated? There's a couple ways, I mean, truly there are a couple ways, and we'll talk a little bit more about this kind of as we move throughout. So hold on to some of maybe your thoughts about this too. But off firsthand, right? There are two ways off the top of my head that I think, well, we can connect with children of incarcerated parents by one, going through our school systems, right? Oftentimes our school systems might know about parents who are incarcerated. Perhaps they don't always, and that's totally fine. So I'm not saying that that's an automatic shoo-in. However, it could be a helpful and promising opportunity to go to our school leadership and say, hey, we are really interested in working with the population of students here whose parents or parent may be incarcerated or have experience with the criminal justice system. And here is what we'd like to do. And we'd love your help identifying if there are any children who may be eligible for these services. Now, of course, obviously, we don't just go right to the kids. There's a process that's going to have to take place with permission and parental agreements and, all the things that you all know that we have to do before we jump right into service implementation. However, it's a great starting point to just have that conversation. For the most part, schools like help. I will also nod and shake my head that I know schools can be difficult, right? It can be difficult to get into. So I certainly understand that it may not be just a walk in and a straight shot and a yes, but it's a great starting point to at least have some conversation. The second way to kind of think about this is go to the detention centers, right? Go to your local jails, whatever your setup may be, and have a conversation with the administration and the leadership there as well. I know lots of local jails or prison systems here locally do a lot of family opportunities. So really working to have that restoration, that family unification is really important to some of the criminal justice systems. Again, I won't say all of them. I'm sure there are some that could share some barriers that they've experienced, and we'd love to hear about that too. However, it could be an opportunity, right? That we approach the administration and have that conversation. Can we come in? Could we do some things? Could we have some interaction with the kids? If you have a family day, could we offer some services or connect in a way that we could have a continuation of services? There are lots of ways to be innovative. And I think that's the most important thing to remember, that while I very much understand that all of our plates are so full and we are so busy, and it can be easy to say, we asked and they said no, and we tried, but we don't give up, right? We keep trying and we keep identifying and keep persevering and finding ways in which to make it work so we can identify and serve that group is really, really important. Okay, I just got to pop up for a question. So let me look at this. So Lauren, thank you for your question. Lauren asks, would you consider students on a college campus as having the potential to be a selective population? I struggle with the idea because they are choosing to be in the situation by choosing to pursue school, but cannot necessarily dictate the environment of the school. I also see them as experiencing a significant transition, which can put additional stress that could put them at risk. So and Richard, you are going to say exactly what I am. So Lauren, wonderful question. And I think you articulated this so well. And yes, I would understand the identification of placing college students in a selective population based solely on the transition from going to college. So what we know is that transition in life, and we'll talk about this too. So this is a great segue question. Transition in life is a risk, right? It's risk. So whether it's moving from elementary to middle to high school to college, transitioning from living in one community to another, moving from a state to a state, or from a school to a school, transitioning from being part of this sports group to a different sports group, right? There's lots of ways in which we can articulate transition. However, we know that transition equals risk always. And so I think you have a great point, and that I think that they very much could be. I think it's specific to Nicole saying what I'm about to say too. It would be probably specific to that incoming group, perhaps because they're the ones probably experiencing more of the transition versus like a sophomore, junior. Now a senior is also going to be at that place of transition because they're preparing to exit, whether they're continuing their education or moving into the workforce or military or family life or all the things, right? That would also be an opportunity to identify risk. So I do think it could be specific to that. I do think that college students are at risk for other things, right? Because of what we know, right? So for me in South Carolina and right here in Columbia, if you're familiar, we are nestled right in the middle of our beautiful University of South Carolina, go Gamecocks. However, what we know is that we've got a lot of students who are at risk because of that. So nestled right next to them is our very popular downtown bar district. And what we know is that there's accessibility to alcohol, accessibility to other substances, and what comes with that type of thing, right? Then you have increased sexual assault, increased violence, increase for harm, increase for damage, increase for drinking after driving, or driving after drinking, excuse me. So all those things kind of add up. So I do think that there can be some indicator. I don't know that I would say all college students are going to be in a selective population. That I wouldn't make those types of statements. But I do think that you can articulate that because of some of that transitional risk, and because of those other types of things, we could certainly identify that they may be at that selective place. And again, situational things are obviously going to take into that. I would probably start with, that might be more, like you talk to all the incoming freshmen, right? And that may be more that universal, but there is some selective identification there because we know that they're at risk because of that first transition. So that's how I view that. I'm not the sayer of all the things. For me, that makes the most sense. So I'm hopeful that that connects for you. Nicole's got some similar feedbacks. She would agree, freshmen or possibly new students or transfers. Great point, Nicole. Just again, that higher rate of sexual assaults. Absolutely. Richard talks about, just did an opioid awareness and Narcan training campaign for my senior seniors at UC Davis and at risk. Absolutely. And then Genesis says, I'm assuming college students who are still living in a parent's home, living at home would be a protective factor. I think, it could be. I'm not off the top of my head familiar if there's research to support that protective factor, but I think certainly perhaps just the environment in which we're in, right, may serve in that way. Depending on where else they spend their time could be a risk factor, right? So it just may depend there. And then Jennifer mentions there has been an uprise in suicides here at college campuses. We have seen very similar things here as well. Unfortunately, Jennifer, and Lauren's confirming, yes, Jennifer, I'm by NCSU, so very similar. Lauren, that was great. Awesome. Thank you, Lauren. I am glad that was helpful. That was a very great question. And thank you all for putting into your thoughts as that as well. That's great feedback, and that's how we learn from one another. So great questions, everyone. Just as we kind of talk a little bit more about the examples of selective populations, we certainly have a couple more just to kind of think about. Another group that's going to be at risk. This one tends to sometimes get some pushback because we talk about how they're not necessarily making, that choice, but this one talks about students who are failing academically. So I just kind of want to take just a quick second before we're like, no way, that's a choice. So certainly there may be students who choose to not put forth the effort to be academically sound or do well academically. But I don't think for this one, the reason in which it's selective is because there are other reasons why students are not performing well academically. And so those are the things we have to identify. So we have a group of 10 students at the middle school that are falling under the line of academic performance. Again, as we get reached out to, we need to investigate why. Why is that? Is it because all of these children's children are perhaps children of persons with a substance use disorder? And is that impacting things in some way? Again, we don't want to make assumptions. These are just questions we ask ourselves, right? But we really want to peel back, like, why are we failing academically? And what common themes do we maybe find that surface? And this is so important, speaks so important to why we spend time figuring it out versus saying, well, they just don't care about school and they are just lazy and they don't want to try. When in reality, there was probably some other things going on, right? Now, you maybe of the 10%, 1 or 2 may be in that category. I have a hard time agreeing with that. I think there's always another reason. And I think it's our responsibility to identify why, what is contributing to the academic failure? What is contributing to the lack of desire to be in school? What is contributing here? Is it some things that the school could do differently, right? Is there some things that we could identify to help the parents identify the importance of school connectedness and family connection to that type of thing? Again, we could get very derailed here, and I won't do that to you all, to create scenarios and situations and solutions. However, it is our job, right, to do that. And so identifying the reasons why some of these groups exist is really important before we just kind of pass it off as like, oh, that's a choice. Not always, right? Not always. So thinking a little bit about that is important. The next is victims of physical abuse and or sexual abuse, however way you maybe want to think about it. Certainly not a choice, certainly not something that anybody selects to be a part of. However, you're going to find that this is going to be a large group, right? And there are selective prevention strategies that we can implement with this group based on this population indicator. And then we just talked about this. So this was a beautiful segue with Lauren's question, that we have families that are experiencing transition. So they're going to be an example of a selective population. And so again, we talked a teeny bit about what those transitions might be. Could be moving. That's a very tough one for young people. It's a tough one for adults too. Sometimes it may be more exciting for adults, but for kids who are, losing their group, losing their comfort, losing their school, that's a large transition. And so it's important to remember that as we work through these populations and really make sense of why they are at risk and why they are in transition, and what does that mean for them, and how can we help, and how can we be of a support, and how can we provide. And so when we think about this, and think about all these populations and all these little bits of examples that we've given that kind of come to our mind, we're going to do a poll question now. So Shannon's going to help get us going. But our poll question that I'd love for you to look at is just a quick one, is what is your comfort level with identifying populations such as the ones we outlined in the examples that we shared? And so you can pick not comfortable, somewhat comfortable, comfortable, or very comfortable. So pick there. Just let me know, what are you thinking? See a couple things coming in. Some not comfortables, totally understand that. We have some somewhats, a couple more people still chiming in with what they're thinking. Looks like we've got about 60% of our participants participating. So if anybody out there is still kind of thinking, go ahead and chime in. We've got a handful of very comfortables. It's awesome. I'll take a quick sip of water while y'all do this. Great. All right, it's looking like it's slowing down, so I won't belabor us. But basically what you all are telling me is that for the most part, about half say that you're somewhat comfortable with this. And then about 32% said comfortable, We've got a nice little chunk, 12, very comfortable, which is awesome. And then just a little chunk of not comfortable, which is totally understandable. It's a new topic for some, right? And something that we continuously learn about. And, the great thing to think about here too, is no matter how long you've worked in prevention, these examples of selective populations literally change every day, right? There can be new subgroups, new populations that, we're like, yikes, never even knew or thought about that group, or never even dawned on me that might be something that places someone in this subgroup or population. And, it shifts a lot. So just kind of wanted to gauge, what your comfort level was as we work on understanding these populations and how we best identify, and then how we best connect with them. And so I think that's a great thing to think about too, is how do we find ways to connect with these populations? And so we talked a little bit about this kind of as we were moving throughout. A couple people said, oh, they were comments on the Zoom or on the poll. Thank y'all for doing that. So it's important to remember that when we are working to identify these populations, we already know that they are going to be experiencing some vulnerabilities, right? Just at that higher level of risk. There may be some trauma, there may be some past experiences. And so we kind of touched on this, but just a good gentle reminder before we kind of hop to our next topic here is really just the delicateness and the gentleness in which we approach these individuals and these groups. And so there already might be some feelings of shame or uncertainty or scared, there could be lots of reasons or lots of feelings attached to these selective populations. And so I think for us as prevention professionals, making sure that we are mindful of those feelings and we validate and hear those as very real things, but also making sure that we remain abreast and current in terms of training and professional development and how we best approach and communicate is really so important. So for some of these groups, we could be the very first entity that has ever reached out to provide any type of positive service, right? So when you think about that, this can sometimes be a humbling experience. Certainly, I've got some examples of work with selective prevention that really kind of took me back. I didn't have similar experiences with some. I certainly have and have been in that selective population. And so being able to have that vulnerability and that connection with people is something that can be really humbling. It's also a very great reminder, and I'm always going to plug this, so I hope it's okay, but it's also a very great reminder to self-check with yourself as you get closer to these populations that have experienced adverse situations or traumatic situations that may or may not resonate with something that you have or have not experienced. The reality in which you feel for these people is so very real and so very deep that I want to remind you that you need to also find time and ways to healthy and safely take care of your own self and your own well-being, and not forget or lose sight of that. We tend to do that as human service providers. And so I just always like to find ways in which it makes sense to remind us of that. And so sometimes this is a great reminder that we may have similar situations or we may not, but still very much feel for the people that we're working with. And we can carry that, and we can sometimes forget that we have to kind of let that go and put that down. And it's our responsibility to provide the service, and we have to shut that off when the time is right. And I'm not the greatest at this, so I'm not speaking from the expert seat. I'm just speaking from a fellow prevention friend seat that encourages you to make sure that you are checking in on your own wellness and taking time for yourself and creating opportunities to take care of that. All right, so we've talked a little bit now about examples of selective populations. And so with a little bit of time that we have left, and making sure that we leave a nice amount of time for questions so that nobody feels rushed through that, I'm going to move us to now talking about selective prevention strategies and what that really means. So what we're going to first do is just kind of share some examples. And so I want to preface that it's some examples, not a conducive list or an only list. It is just a nice overview. So there are certainly more that are going to be out there, that are going to be something that we can have opportunities to talk more about or to look at, things like that. So with that, Let's talk a little bit about that. So what we have here are some examples of selective strategies, selective prevention strategies, interventions. People like to use both of the terms. So what we're seeing is, first and foremost, an opportunity here to offer some support groups, right? Support groups for children of persons with substance use disorders is one example. Now, sometimes people get a little hyper when they hear the word or see the word support group and prevention. So it's important to remember that support group doesn't always mean treatment. It could be, right? But it doesn't always have to mean that. So first and foremost, we just like to kind of remind people that a support group is truly just that, right? A group where people who are living similar experiences can come together with someone who is trained to facilitate the group, and have opportunities to connect, communicate, access resources, work through maybe some difficult situations, maybe develop some resiliency skills, some communication skills, some planning. Lots of different things can happen in a support group, right? So I'd just like to remind people that it doesn't mean treatment, and we don't have to worry too much about that. And so again, these are groups that are identified based on membership of a group that's not really by their choice, but that's where they are. That's where they have found themselves. So there might be opportunities within your local agency. So for me, my local agency that I'm at is a prevention, treatment, and recovery support type holistic agency. So for me, it could be very easy to go just down the hall and talk to our director of treatment services and say, hey, I'd really love to explore opportunities to maybe work with the kids who have parents that are diagnosed with a substance use disorder. Again, we don't just say, okay, and get access to the kids. There's a process, right? Permission, scheduling, planning, all those things. But perhaps we could offer simultaneous groups, right? When parents are coming for their group service, maybe we have some opportunity to work with the kids. So there are ways in which we can do it and do it well with some positive outcomes. That's just one brief example. Certainly there are others we could probably expand upon. The next one is really focusing on training programs for youth that are placed at high risk. So how can we utilize this subgroup and not kind of push them off to the side, but utilize them with training programs to help them be strong leaders, strong communicators, kind of pioneer specific things. What are some ways that we can help them hone in on some skills, right? Because of what places them at risk, but also just for some general things, right? How can we do that? Those are some examples there. We also have media campaigns. Sometimes people are like, no way, media campaigns are universal. In general, they are, but if your media campaign is going to target high-risk youth by way of messaging, by way of demographic reach, specific indicators that are focusing in on that high-risk group, it's selective, right? And so how do we do that? How do we partner? How do we identify what our young people need to hear or see or learn about through these media campaigns? And then we build it. We build the campaign and we implement it, and we evaluate it always, right? For the outcomes. We also have opportunities like workplace prevention programs. So are there ways in which we can implement things in the workplace that would identify and target those selective groups? That one may be a little bit more difficult, but certainly is an opportunity to look at and investigate. We talked a lot about this already, so just a great reminder that there are ways that we can implement programs for families experiencing transitions, right? We could host a town meeting. Families that are new to the area come out. Snacks and refreshments provided. Maybe, I know food can be an issue sometimes. Maybe you can partner with a local community group that might provide the food for you. Ways in which we can connect with community based on specific things is really, really helpful and really important. And then kind of on the flip with support group, remember support groups, not treatment, support groups for parents of high risk youth. So we work with the parents that have the same type of struggle. So it isn't always the kids, right? It's not always the youth that are going to be in the selective group. It can be parents and adults too, right? So we could do the same flop here. I could go to our adolescent treatment director right down the other hall and say, hey, when you have your adolescent group night on Wednesday, I would love to do a parent component and bring the parents in, and we talk about certain things, and communication, and how we set healthy boundaries, and how we maintain these boundaries, and how we have early and often conversations, and how we create plans and things like that. Not that we're criticizing anybody's parenting skills or saying that because of poor parenting, that's why your children are here in services at all. This is more about providing that resource for a subgroup based on their risk level, not by their choice, right? So just another way to kind of think about an opposite, and making sure we're not only thinking that selective means kids, it really means across all ages, not right? It's common for kids, but it's not just kids. So these are just some examples of some selective strategies as well. Again, a very brief list. There are certainly more we could add. All right, we are going to do another poll question first. So Shannon's going to kick this one off for us. You will see that here. The first one that you are going to see is, how frequently are you implementing selective strategies in your communities? So Shannon is going to set that one up. And once you see it, you can just actually, this is not a poll. Shannon, I'm sorry. This is a chat. Shannon she's so kind, you guys. This is a chat. I apologize. So in the chat, if you could just type in how frequently you are implementing selective strategies in your communities. Is it a big thing for you, a big focus? Haven't touched it yet? Still trying to figure it out? What are your thoughts? I mean, how frequent is it happening for you? Thank you, Shannon. You'll see in the chat, Shannon has it typed. I'm sorry again, Shannon. So some are saying not sure, we're setting up new programs, so doing lots of needs assessment. Oh, I love that, Nicole. You are starting in the right place before you jump to implementation, so you get a gold star, because sometimes we go right to implementation and don't do any assessment. So great job there. Amanda says not personally, but yes, doing some. Lindsay says none yet. Well, Marie says a big focus, great. Lauren saying not often enough. Oh, I relate so much to you, Lauren. Universal seems to be the go-to for us, but I'd love to get more selective. Me too. Lena's doing daily. That is awesome. Saleha says often. Mackenzie, not often. Brittany also not enough. I relate. Great. Wayland says most of what we do. That's awesome. Still new, so not a focus yet for Jamie. Not often enough. Anna, I relate to that. Genesis, same, more universal. Carlos doing often. Jasmine once a month. Kayla, I agree. Most are universal's comfortable, right? Gabrielle says none yet. Oh, Pamela, that's great. Regular prevention on campus. That's awesome. Jennifer still working. Steve says there's a gap in our prevention system. I understand that. James has quarterly through local cultural center. That's great. What a perfect example of an awesome partnership, right? So it doesn't always have to be us. Remember, we don't always have to be the ones on the hill going down with the ship. The only sole prevention people. Get with your partners, figure out how to work together. Bertha says not available. Raymond's frequent. Miriam, not at all. This is new to me. Excellent. Oh, great, Miriam. I'm so happy. Jessica says often, but also depends on grants and programs. Absolutely. Somewhat still building. Great. Oh, so Sandra, this is another perfect example. We take advantage of many community events to implement strategies. Perfect, right? Don't recreate the wheel. There's probably something already happening that you can tap into and just be there. We do that too. Great. Once in a while, Carrie, little, most of universal. Yeah. Shauna, we're doing our yearly assessment. Great. That's a great reminder too. Do those assessments often, so you know that you're focusing on the appropriate things. Peyton says not in the implementation phase yet for my grant, but organization implements some selective population intervention through. Great. Perfect. Awesome, you guys. So this is a great kind of starting point, right? So most of you are doing this quite a bit, which is, and for some, I can relate so much that you wish you could do more selective. And I completely understand that the focus on universal tends to rise to that top, and that's not a bad thing. It's very common, but I can also see that the need and the desire for more is there. I relate to that very much. All right, we're going to do another chat, not a poll, another chat opportunity. So if you could see question 2, and let's share what are some common barriers that you've identified when implementing selective prevention strategies. I'll give you guys a few minutes to think about that. What common barriers have you identified when implementing or attempting to implement selective prevention strategies? All right, here we go. We've got some coming in. Let's see. Steve says reaching the target population. So that can be so hard, right? Because it's almost like they're surfaced, right? You have to identify that the population exists, and then how do we even get to them? So it's like a two-part, which is why it's difficult and takes more time. And so sometimes that may be a reason, certainly not saying it's Steve's reason or anybody's here, but could certainly be a reason why selective prevention doesn't happen as often, because it takes a little more time to get to it. Sandra says language, very, very, very good. Clarissa, mostly universal in schools, but we have some selective, great. Not enough time, Rhonda, right? Not enough time. Selective prevention is difficult. It takes more time than universal. It's not that cookie cutter. We run in, we run out, everybody gets it. They all get it the same. Not saying that we're not doing our very best with universal prevention, but it's easier for the most part, right? It can be easier. Pamela says administrative support. Absolutely. Oh, Lauren, not enough capacity all day long. Community not utilizing the fullest capacity, almost like pushback. Angelica, yes, it's difficult, right? It's because it's you're drawing attention to those uncomfortable type of conversations that many of our communities are still struggling with. And so absolutely. Kayla talks about time, money, recruitment. Absolutely. Well, Marie says language, and some parents that do not want outsiders to be involved. We get some pushback there too, a little bit, kind of keeping the issues close to the chest and not letting anybody know about it, right? Jessica talks funding and capacity always. Lynn talks about the awareness of the need. That's a beast in itself, right? How many times do we identify a problem and we are like beating our head against the wall trying to create awareness and attention, and we just don't ever, it just falls flat. When your community is not ready, you have to kind of stop and pull back and work to get them ready. And that can take a long time, and it can be disheartening. Absolutely. Schools have like restrictions. Yep. Schools make it hard. Language, conservative parents can be so difficult. Florina, I understand that. Jeff talks about recruitment, not enough staff. Brittany, absolutely. Deshauna talks about reaching our disparate population. Yep. So many of our resources need to be translated to another language. So difficult, so difficult. So many steps, right? It's when you have a group, that's the hard part too. When you have a disparate population and they want you and you're not ready, right? Oh, can be hard, right? But staying connected and staying with them is a great way to work through that. Bertha talks about funding. Rebecca talks about approaching a group and not having them feel singled out. That's a really great point, Rebecca, right? So how do we not draw attention in a negative way to a group that's already kind of vulnerable and probably has already experienced some of that backlash? Absolutely. Language, stakeholders not wanting to implement. Anna talks about wanting community members not wanting prevention programs. Yeah, community pushback, absolutely. Oh, Tanya, yep, getting parents to complete the screening forms, so difficult. Time and budget, competition time for the classroom, James, that's a big one, right? Living in a rural area, Kayla, relate to that. My office is in downtown Columbia, but we stretch out to some very, very rural pockets. It's difficult to get out there. Or to make them feel, like you're saying, targeted. Absolutely. High stigma, Shauna, all day long. Youth prevention club that's provided and is accepted. That's great, Amy. Awesome. Thank you all for your feedback. So just some helpful things to think through. First and foremost, I hope that it shows that all of us are experiencing probably the same barriers. So if nothing else, I hope you feel a little bit less alone in your daily strive and struggle to implement selective prevention strategies. Nicole says, very new to prevention, but are there EBP libraries where we can find? Yes, there are. We talked a little bit about this last week at our overall type thing. So I think you can get that. Shannon might be a better one to tell maybe if that lives somewhere or if it would live somewhere, those slides. But yes, we did include some examples and some registries. Several local agencies are staffed by individuals who are not local. Yeah, that's hard, right? So people know if you're not specifically from that community, and it can be just a hard time to find that connection. Absolutely. All right. Well, thank y'all so much for your feedback. These were some great conversation points. All right, so we are moving and grooving here. We've got about 10 minutes. So let's talk a little bit about effective implementation of these strategies. This is obviously something that's so important that we don't forget about. And so the first thing that we look at is really around selection criteria. So really understanding and asking is the program or practice effectively addressing 4 things? First being, are we focusing on addressing the substance misuse problem that we've identified as being kind of at that forefront? Secondly, are we identifying and addressing the associated risk factors? Is this an opportunity to increase protective factors? And is this a good fit for that specific community, specific subgroup? Now, again, we're busy people. I get it. And sometimes it's like, if it's a good program, that's what we might say, but we haven't really identified through the use of using those EVP registries that we were just talking about. Is it a connection? Is it a good fit? Is it going to impact what I want to change? Is it intended for the target group? Is it intended to change risk and protective factors? Is it even addressing my overall problem? If we have no's to these questions, I'm so sorry to be the one to tell you, but it's time to pause and step back and figure out what's going to get us to the yeses, right? If we willingly move forward with all the no's, we're really doing a disservice to our community. And again, with selective prevention, we're already dealing with a group that's vulnerable and experience some things. So to do more harm is really not in good taste or good practice. So really, really helpful to think about these criteria as we're working through the selection process, while understanding that we may have to step back a little bit and take a minute before we jump right into implementation. So what's important is that we want to make sure that we are working through these selection criteria before we jump into any type of implementation to be the safest for our community or our subgroup, excuse me. Once we get into implementation, it's very important that we make sure that we are maintaining fidelity. Always hear about this, right? But let's talk about making sure we know that fidelity maintenance means that we are implementing the program to the degree in which it was intended to be implemented. Quick example, if it's a 7-week session and you can only give 5 weeks, you got to take a minute and figure some things out, right? We don't just do the 5 weeks and say like, well, I did my best without having some conversation. So one option is to contact the program developer, explain your situation, let them give you some feedback about ways in which you could make some adaptations perhaps. But at least do that before you just decide to cut two things out or merge them together. We don't want to do anything that will harm the integrity of the program or the outcomes. And so with that, we maybe make some adaptations, which is really the way in which we, maybe have to change to meet local circumstances. I'm not saying that doesn't happen, but we want to have something structured in place before we just kind of do that and jump into it. So that's what we mean about the effective implementation, implementing it as it was intended and being mindful when adaptations might have to be made and making sure we've done the correct diligence and research before we just kind of do it. Yes, Joe says most developers are happy always. I've always had great experience having to contact someone. So make sure you do that if you have the ability to. All right, friends. Well, that is it. I think we have like 5 minutes. This happened last time too, so I know we don't have a ton of time for questions. But certainly, if you have any, I know there are a couple slides that either we just want to end on as well. So questions or thank you for the minutes. Waylon says, thank you for the many nuggets to think about in our work. I too attended last time. Okay, so Shannon, that might be for you about certificates. Any questions that are coming up for anybody? Okay, well, as people might be thinking about any questions, I'll keep an eye out. I think we've only got like 3 minutes until we are supposed to be done. So there are a couple slides to end on. I will push to those as we are looking at the chat for you all to see. As Chuck and I and Shannon have mentioned, our third and final webinar series on this series topic will be next week, next Thursday, the 31st. And you see the central time is 9:30 to 11. So we will be focusing on indicated prevention strategies to really close out our time together. So hopefully you all can join us. Let me peek and just see. Thank you. Okay, no questions. Thank you. Thank you all for the kind words. I'm glad that you were here and enjoyed it. Last little bit here. Some other trainings coming up. We see a couple of them may be full, but you have a couple opportunities here as well. So make sure you are saving the date and checking these great PTTC Great Lakes trainings coming up. And same for 3 new Healthy Knowledge courses. So if you are not familiar, this is an awesome resource. So make sure you check these out. Great information on social determinants of health, health equity matters, and I love that, prevention's role in harm reduction. That is great. I'm kidding. Thank you. Shannon is putting the evaluation survey in the chat. If you could take a few minutes and give us some feedback, we love to hear it. Ways that we're good, we're not great, things to improve upon. Please give us all the great information. Couple more things to look at, some resources on Great Lakes PTTC product page. So if you are looking to have a little bit more resource and information, these are some great links and some resources for prevention providers to look at. Great for those that are new to the field, but also good refreshers. So even if you've read it once, it's a never bad idea to go back and read it again. This is your QR code and your link also for our survey. So you will see that Shannon put that in the chat. She also put a link to the session from last week in the chat. So if you were not able to be there, or if you just want to go back and listen again or revisit some things, make sure you check that out as well. We've got some registry links being shared, so certainly check those out. And then always, of course, we're going to include our references where we got all this great and helpful information. So you'll see that here on slide 1 and slide 2. And that brings us to just about 12 o'clock. And then we've got 1 minute, 11:59. So we've got 1 minute. Any other last minute questions? Shannon is also linking the evaluation. If you've not seen that, please make sure you click that and complete that evaluation for us. Just as last session's recording lives in an archive, so will this one and will next week. So if you're not able to join us, you can always go back and check that out. But as we now approach probably 30 seconds, I would just love to thank you all for joining us today and for being a part of this conversation and being so participatory. That really helps things and allows opportunities to learn from one another. So we've got Steve, I believe Shannon will has information on certificates. Of course. Tiffany, from my understanding, it will be recorded and you can kind of reference the slides that way. And normally they link the slides as well. So yes, thank you, Shannon. Thank you. Any other questions? Oh, y'all are so welcome. Thank you so much for your feedback and kind words and for being active and participatory. I'm sorry, James. Yes, I do. We do move quick. Yes. The slides and the recording will be on the PTTC website, so you can always go back and check it out. Awesome. Well, it is 12 o'clock and we want to be mindful of your time. So with that, we will tell you goodbye and hope to see everyone next week for our final series. And have a great day. Thanks so much.